And now, for a moment created by our underwriter and sponsor, Novo Nordisk, I'm pleased to introduce and welcome to the stage Dr. Todd Hobbs, Chief Medical Officer of Novo Nordisk North America. So, Todd, the stage is yours.
And I promise it'll just be a moment. It won't be a long moment. But no, thank you, Emily. And good morning. I'm Todd Hobbs. I'm the Chief Medical Officer in North America for Novo Nordisk. We are a global healthcare company with a focus on innovation and leadership in diabetes for over 90 years now. We're certainly proud to underwrite today's program. I think already you've heard just the teaser of some stimulating conversation. We had a summit earlier where we had a lot of good ideas that I hope that we can connect later on. And I'm also here pleased to be talking about, or at least recognizing, that tomorrow's World Diabetes Day, as was referenced earlier, the world's largest diabetes awareness campaign. And we're joining over 100 countries around the world to hold activities that are dedicated to really giving a more powerful voice to diabetes awareness and advocacy. And this is extremely important around the world. And again, thank you all for coming to this discussion today on diabetes. We know it's a global epidemic. We've heard some of the statistics, significant public health impact, especially here in the U.S., obviously. And we all know the statistics. Again, over 29 million diagnosed, probably more than that now in the U.S. with diabetes, 10% of our population. And tens of millions, 86 million is what we've found as risk for prediabetes. But yesterday, the International Diabetes Federation published their updated guidance. It's a little bit more striking. 415 million around the world have diabetes. Half of those don't even know they have it. So half of those are undiagnosed in many countries where they don't even recognize or receive care until they've had significant complications. So 1 in 11 adults worldwide have diabetes. So this is something that we need to be aware of. The disease, as we know, is complex, and I agree there's not going to be one solution. There's not going to be one person or company that does it, and we need to make our efforts together to turn the tide of diabetes. We have to, I believe, improve detection and prevention if we're ever going to make a dent in these numbers of care of diabetes living in the U.S. So taking this serious disease and hitting it head on, it requires knowledge, obviously, but passion, and you'll hear some of that today with several of the panel, and a commitment from a broad range of stakeholders, many of which we have here today: business leaders, government, pharma, obviously, healthcare providers, academics, community leaders, and also patients need to get involved in this. We need to hear their voice. But it does take R&D and research and development, and obviously that's where much of our interest and specialty lies. And we know we have to continually improve therapies for those patients that have diabetes. And a key topic in discussing this therapeutic innovation is value. And how do we improve the value of these innovations? And the value is measured in different ways. The patient values something much differently than the shareholder, for instance, and so that we have to really recognize that. It's been over 5 years now since the Affordable Care Act has been passed, and we see shifts that we know are occurring in the number of patients who are getting access to care, and that is a good thing. But we're also seeing that the cost of this care is being shifted as well, shifted to patients more, to employers more, and I believe we're actually going to see that's going to start to negatively impact the overall care of diabetes, and we're already starting to see that to some extent. And at the very same time, as we mentioned, we're facing staggering numbers of Americans with chronic diseases like diabetes. And so given these trends, it's no surprise that the cost of healthcare delivery is a very hot and frequent topic in many national debates. The price of specialty medications has certainly become a hot button in these debates as well. And more than once, the question of, will these specialty medications bankrupt the healthcare system? And I really don't believe they will. Now, there is a high cost of specialty medications in the short term, but overall, if you think of chronic disease management, the cost of managing that disease should go down as more patients are treated. And the reason is because in the long term, the cost benefit to the healthcare system as a whole, as patients are cured of serious diseases, and for example, with hepatitis C, which is the one that sort of triggered this national debate, there is a cost benefit for these treatments that really not many people are talking about. When you delay the progression or you cure the disease, it actually would lead to organ failure and significant costs in the long term. So we need to keep that in mind. And then what I truly believe does, though, have the ability to bankrupt our healthcare system is the chronic diseases such as diabetes. And for example, there's roughly 3 million Americans with hepatitis C in the U.S. And as mentioned many times now, over 10 times that many have diabetes. It's just staggering. And another 86 million, the tip of the iceberg, with prediabetes, and that those numbers are increasing. And if you have prediabetes, we know that there is really about 30% chance that those patients will go on and develop diabetes within 5 years. So this is really something that needs to be recognized sooner. And if current trends continue, by the year 2050, it is estimated that 1 in 3 of us in this room will have diabetes. So it's here. It already has a profound economic impact. It costs at least $322 billion to America to take care of diabetes. 1 in 5 healthcare dollars is spent on diabetes. 1 in 3 Medicare dollars. 1 in 3 Medicare dollars on diabetes. And even more concerning is, again, the cost of complications from diabetes represents about 61% of the overall cost. So the pharmaceutical side of it is certainly one piece of it, but the complication side is really that big staggering number. At Novo Nordisk, we certainly want to try to reverse these trends. We have a bold vision. We want to defeat diabetes in our lifetime, and we can debate, and that is a steep challenge, we know, but that's our mission. We are dedicated to innovation in diabetes and other chronic conditions, and we put really our money where what our statement is. We put over 15% of our earnings each year back into R&D, so we really want to continue to push the needle there. But we know that achieving this goal of potentially a cure for either type 1 or type 2 diabetes is not about searching for a radical innovation or some magic bullet. We recognize that. Certainly insulin was once a radical innovation for patients, including myself, who live with that every day. But innovation really doesn't end with discovery. And since that first insulin was found in 1923 and begun to be used out there, we've seen continued incremental innovations. And we have to have these incremental innovations, and they have to be rewarded in the marketplace, or else they will not be able to continue. So we need to figure out how to have those value discussions for the incremental innovations. For example, when you look at human insulin that we had for some time, we had beef and pork, but then human insulin. Now we have analog insulin, which has come over the past few decades, and this has offered tremendous advancement to patients. It's allowed safer and more effective glucose control, and we know that leads to improved long-term outcomes. And also now improvements in delivery systems of insulin with pen devices and insulin pumps, et cetera, that made advances. And again, with someone living with diabetes, I can say my own testimony is that because of my active lifestyle and probably much too frequent travel, thanks to my Novo colleagues who have me do these things, you know, if you looked at using some of these older insulins, I would struggle with hypoglycemia, and I probably couldn't take advantage of the glucose sensor and the insulin pump that I have now that really keeps me able to do the job that I do for Novo Nordisk, and certainly my family would be affected as well. So for me, the value is tremendous, but for my healthcare provider and my system that looks at the costs that I bring to that healthcare system, they may look at that differently. So it's with different eyes. For type 1 diabetes, I do believe we will see potential for a cure in my lifetime with beta cell encapsulation and transfer. Also looking at the closed-loop delivery systems are really making quick advances. But because of the complex nature in type 2 diabetes, which involve multiple contributing factors, and one of which is the patient's own lifestyle, I think we really need to look, as I mentioned, at that prevention and improved control. And it's more about better medication for sure. And we really need to channel our knowledge in the disease into initiatives aimed at this prevention. Some of those examples include our support for increased screening with the USPSTF Task Force guidelines to find those at risk who currently have prediabetes and driving the interventions necessary to prevent the progression of type 2 diabetes. Now, we know the revised federal screening guidelines we could debate may not go far enough, but it's a step in the right direction. Also, Novo Nordisk, you're going to hear a little bit more about this. The Cities Changing Diabetes program is the first of its kind public-private collaboration, which is really developed to stem the tide of urban diabetes. And we know diabetes is everywhere, but it is also in the cities at a significant and amazing level, and we need to address that. We want to look for long-term solutions. And the partnership really aims to tackle the challenge by first understanding the driving factors behind the rise in diabetes in these specific areas and what in that culture is contributing to this. We're going to hear more about mapping diabetes in the cities today from Dr. Faith Foreman, who's from the Houston Health Department. who was instrumental in convening and growing the partnership in Houston for Cities Changing Diabetes. And also Cheryl Bettiglow, who's Director of Chronic Disease Prevention, Department of Health down in Philadelphia, near where I live, and efforts that are being made there. And we did hear from Dan, although he had to leave, but some excellent insight about the role nutrition plays in type 2 diabetes and treating that and certainly addressing it. And as I mentioned, the Affordable Care Act has made great strides in extending health care coverage to millions. But unfortunately, this expansion of care may not actually lead to better outcomes. Many patients struggle with chronic diseases. They're struggling due to the high out-of-pocket costs associated with some of the lower-cost plans that they choose in the selection. And as patients weigh these costs against their treatment, we know that they may choose to skip or reduce doses of medication, insulin being probably the number one that gets skipped or reduced, or they make fewer visits to the doctor. So this is not a good thing. We know that people with diabetes who do not have health insurance have 79% fewer physician office visits and are prescribed 68% less medication. That's not a good thing. They also have 55% more emergency department visits than those with health insurance. So we're starting to see this, as I mentioned, trend for those who are underinsured. They're not uninsured, but they're underinsured, that meaning that they're covered, but they really don't have the ability to manage the out-of-pocket burden to have the care that they need. And one of the challenges we're seeing in now healthcare and how healthcare plans look at chronic disease in the U.S. We're in the U.S. a portable system. Basically, patients are enrolled for maybe 18 to 20 months on a plan, so chronic disease is not really in the discussion. It's more about acute care, and we really need to focus that to have them understand the value of the chronic disease management in their patient population. And in contrast, in other countries that have less dynamic systems, the U.S., we focus less on that long-term outcomes and less on population health. And it has to be a public health emergency for us really to do anything about this. And as a society, we have to find a way to balance the increased short-term costs of appropriately treating chronic diseases like diabetes versus the enormous long-term costs that's going to come if we don't do so. We also need to stop pointing fingers, and that's easy to do, but we need to stop pointing fingers about the responsibility for these healthcare costs, and it's important for all sides to contribute on behalf of the patients. And from our perspective, some of the things that we think would like to see and could advance this objective is among payer groups. We'd like to see more synergy. What factors do they use to choose what drugs are on their formulary? Many times this is very closed door, if you will. And we have big data now. We hear people talk about big data, and that's really how we're going to use that. It's the buzzword. But how can we use this data to make sure the right patients get the right medication at the right time? And that's most important, I think. We have a lot of clinical trials that we need to get drugs approved in the U.S., but what endpoints in those trials are important to payers so they can make better informed decisions about getting that drug to their population of patients? And then can these individual organizations somehow collaborate and agree upon these endpoints? Because right now we have a multitude of different endpoints and it's impossible to meet all those. And at Novo, we believe that capturing the actual experience of patients outside of these carefully controlled clinical trials is very important because that helps inform us of the real-world nature of treating diabetes, type 2 diabetes in particular. And we have ongoing research partnerships with the Cleveland Clinic to analyze this real-world data within its integrated healthcare system to identify opportunities to improve these outcomes. The analysis of this real-world data provides valuable information to us and others around the burden of diabetes, how to treat it, the adherence to medication, and all these health outcomes. And ultimately, managing the healthcare costs requires a multidisciplinary, collaborative approach from many of the individuals like yourselves who are in the room today. We must focus on this shared goal, and we must start now. And we must accelerate innovation without burdening the patient with that additional cost, and this is very important. And we must find ways to reinvent drug pricing and increase the transparency around how this is done without sabotaging the shareholder value for that. And going forward, I think the benchmark has to be the positive impact we have on patients' lives, with especially high marks on disease prevention. We must make any progress where we can, and I certainly know that programs like today are going to be able to do that. So thank you. I know it's going to be a fun morning, and take a couple quick questions if that's possible. Or are we out of time? That's fine. Yeah.
Thank you.
Absolutely.